Engaging our veterans is critical to the success of innovation at VHA. Our success as an organization is dependent upon providing and sustaining meaningful engagement through the innovation lifecycle, and the value that is returned to our stakeholders only increases when meaningful engagement is prioritized in an innovation ecosystem. Our next panel of experts have achieved tremendous success in driving strategies for creating and sustaining engagement across VHA. To begin this conversation, I'd like to welcome Dr. Arash Harzand, Co-Director and Chief Health Advisor for the Digital Health Platform at VHA Innovation Ecosystem. Please give a warm welcome to Arash.
Thank you. Good afternoon. Good afternoon. I think the mid-afternoon slump is starting to settle in. And as Eric was pointing out, we're going to have a session on creating meaningful engagement, so that requires an engaged audience. So for the third time, good afternoon. There we go. All right, well, it's great to be here. I'm very excited about this panel because I think we've heard a lot so far about a lot of the tools and innovations we're building. We've heard words like adoption, implementation. These are all very important things, but things don't really work unless we have a way of getting them in the hands of the people that we want to benefit from them. So engagements are a really core part of what we do in the innovation ecosystem. We have a great panel. We have some really good speakers. We're going to talk a lot about what that looks like. We're going to talk about what meaningful looks like. But to start us off, we're going to have some remarks from someone who I just met, but I'm really excited to hear from more. Her name is Michelle Hulko. She is I'm going to try and get this right, the principal architect and scientist at Google Public Sector for Healthcare and Science. All right. I practiced that like 5 times. And I learned last night is a former Presidential Innovation Fellow as well, so a lot of common threads. So I'm going to walk away and let Michelle take it over from here. Good luck.
Awesome. Thank you so much, Arash. I'm looking forward to our panel and to talking with all of you. And so I want to start by actually giving you the BLUF. Does everybody know what BLUF stands for? Bottom line up front? Okay. In the tech sector, we also use the term TLDR, which means too long, don't read. And that just kind of feels rude. So I like BLUF better. I'm going to tell you the punchline, and then I'm going to give you the long version. And since we're behind time, I'm going to give you the short, long version. So the punchline is, from my perspective, what I've seen throughout my career in terms of creating meaningful engagement when it comes to innovation and technology, 3 things are the critical ingredients: technology, people, and partnerships. Okay, so now for the long version. So technology, people, and partnerships. And I'll weave those threads throughout. So my background is I'm a PhD scientist in genetics and bioinformatics. And so I grew up in the academic research space. And that's really where my first understanding about how technology enables science and research and what we can do, essentially. Because I was working at the time before next-gen sequencing really took off, when microarrays were very popular. I don't know if anybody's familiar with microarrays, but we went from having to look at 1 gene at a time to looking at thousands of genes at a time. And then now with next-gen sequencing, you don't even need to know what you're looking for, and you get all of the genes that you want. But what that does is it creates all of this data that I then didn't actually know what to do with. Which is kind of why I got into this technology space of like, once with technology, when you're able to do different things, then how do you respond to it? And so that was basically my graduate's work and my postdoctoral fellowship. And then almost all of my career since then has been spent in the public sector until I came to Google about a year ago. So I started out as a staff scientist at NIH, helping them with their databases, so really focusing on the data piece of it. And I was trying to do kind of technology implementation from that standpoint with their primary data archives. And one thing that I learned is in 5.5 years, I had the ability to develop one tool not because of any lack of willingness on my part or my team's part, but just because of the nature of what we were having to deal with, all of the volume of submissions. And so that innovation and that technology evolution piece was slower from within the government. And so I realized if I really wanted to be in this space of evolving technology and kind of creating a new state of the art, I was going to have to move out into the private sector. So I went to Booz Allen Hamilton and was there for about 6 years. But most of the time, I was loaned back to the government at DARPA in the Biological Technologies Office. Is everybody familiar with DARPA? The Defense Advanced Research Projects Agency. So the Biological Technologies Office was 1 year old when I started, and I was actually working the Prevent the Next Pandemic portfolio, which we've seen a lot come out of that. We were funding Moderna back when it was a really little tiny company and nobody knew about mRNA-based vaccine technology. But we were also looking at wearables and other types of technologies for understanding contagious spread, pre-symptomatic infection detection, and things like that. And the thing that I learned at DARPA was it's not good enough just to have the technology. You also have to think about the end point of what is that technology going to do for you, or what do you want that technology to do for you? And so still I was kind of stuck in this technology place. And then after DARPA, I went back into government as a White House Presidential Innovation Fellow. And while I was there, the first job that I had was working with the All of Us research program. And they thought that I was going to help them with their genomics data. Turns out they didn't have any at the time. They do now. But I was there with a term appointment. So I needed something that was going to, we were going to be able to get started on. And so I ended up working on their Fitbit data and creating a data product out of their Fitbit data. They now have Fitbit data on about 9,000 diverse Americans across the country, some up to 4 or 5 years worth of data. So it's quite a large data set. But one of the things that we noticed was the premise of the All of Us research program, which is basically about enabling precision medicine research. So how does, instead of clinical practice being one size fits all, how do we figure out, what the difference between treating my disease is and treating your disease, right? And based on who I am, my demographics, everything about me. But in order to do that, you have to have a diverse enough population to do the research on in order to figure out what those differences are. So diversity is a critical goal of this program, and something that the program has spent a lot of time thinking about. And so one thing that we noticed when we made the Fitbit data product, it was a bring your own device model, so people had to have their own devices and bring them to the table. We noticed that we were losing diversity. And that was a critical stopping point for me because the whole point is diversity, right? And so we did a short survey with the federally qualifying health centers that are part of the program to try to understand, what's happening here. And so this is where I come to the people part, because it's not enough to just implement the technology. You actually have to listen to if people want to use the technology, how they feel about sharing their data, if it works for them, if it's giving them valuable information, and all of those things. And so, that was a really important piece of work, I think, for me in terms of, taking it, moving it past to when you do the implementation piece, how are you going to actually be successful? And so coming back to now, sitting at Google where I am, one of the things that I love about where I sit right now is that I actually have brought all of the government mission with me into where I sit at Google, and now I have all of the amazing technology at my fingertips across all of Alphabet to think about how we can solve government mission problems with that technology. But again, it comes back to the 3 respects at Google are respect the user, respect the opportunity, and respect each other. And I think this is a really important thing to consider as we continue in this implementation and creating meaningful engagement, is that respect the user is always the first respect. So respecting the user, thinking about the user, what's going to be useful. And then lastly, partnerships. I think we have all seen probably the way that public-private partnerships, cross-sector, cross-disciplinary partnerships are critical. So again, when I come back to this Fitbit example, another step that the program has taken is to create a partnership with Fitbit to actually distribute devices. And they're working through that, because how do you actually distribute the devices in a way that means that you're bridging that diversity gap. And again, do people even want them? So there are a lot of issues to encounter along the way. But again, I love this quote that, if you want to go fast, go alone. If you want to go far, go together. And I think we are at this critical juncture here where we have a lot of abilities because of the evolution of technology, because of the innovation. But now if we're going to make that step into implementation, we really have to work together. So thank you very much, and I look forward to the panel.
Just step here. All right, thank you, Michelle. So we're going to go ahead and bring the rest of our panel up on the stage. They want to join me. All right, so we're going to try and get us back on track. So want to leave a good time for Q&A at the end. So I think what we'll do is we'll let everyone sort of go down the line and introduce themselves and sort of say how great they are. And so Michelle, you're right next to me, so why don't you go ahead and just maybe. She's already done. Everyone knows Michelle. Bryn.
Hi, everyone. You're probably sick of seeing me. I'm Bryn Cole. I work within the VHA innovation ecosystem as the Director of Design and Storytelling. My whole VA career has really been dedicated towards making VHA more human and more relevant, and I'm really pleased to be joining this super smart group of folks.
Oh, I guess. Hi, everyone. My name is Sandeep Pullum. I'm a medical director at a company called Bioformis. I'm a physician by training, spent the last 10 years building digital tools to connect doctors and their care teams virtually for requesting and receiving care. So looking forward to sharing our thoughts today.
And I'm Ernesto Ramirez. I'm a senior manager in consumer analytics and research as part of Evidation. Evidation is a large-scale consumer platform that is trying to invent and use new ways to measure and improve health in everyday life. I'm also one of the BYOD Fitbit members of all of us.
Awesome.
Nice. So, I wanted to start off talking about really the core, concept at stake here, which is, what is meaningful? And really, what does meaningful look like? And who defines it? So I think I'd be curious to hear kind of everyone's thoughts on this, because I think it kind of touches on really everything that we're doing. So we'll kind of go in reverse order. So Ernesto, we'll let you sort of take the first stab.
Sure. So we at Evidation support a lot of different programs. We do work for biopharmaceutical companies, for the government. We actually did a lot of work in infectious disease for BARDA. And one of the things that we always start with is actually one of our core company values, which is putting the individual first. So we always think about what is meaningful for the actual individual. As part of that work, over the last year, we've actually supported a heart failure project in collaboration with the American College of Cardiology. And we actually did a lot of pre-work before doing any actual work of putting together that platform, writing any of that code with patients that are on our platform that had heart failure to try to understand what could be meaningful for them. And it turns out they want to have better conversations with their care providers. So we started with that lens of what is actually going to be meaningful for them, what kind of conversation do you need? And it turns out when your physician's going in and saying, how are you feeling? What's your symptoms been like? What's your weight been like? It's a lot easier when you can just present a report and say, this is exactly how the last 30 days, or this is the last 90 days of my life. Let's have a conversation about it. And so what we ended up building around that was a really nice and quick, easy system for individuals to input data that mattered to them, but then could be fed back into a way that would enable them to have that conversation with their care provider.
Sandeep?
Yeah, no, it's a great point. We actually at Bioformis look at it for all the stakeholders, right? Meaningful means has to have value to the patient, let's like you described, but also making sure that that information fits into how clinical decisions are made, right? So our whole job is to simplify that process by consuming information from multiple sources, wearable devices, patient-reported outcomes, going through our analytics, FDA-approved analytics engine that makes those decision points easier for the clinician team. So it's engaging both the patients and the clinicians in achieving meaningful outcomes, essentially. That's the way we think about it.
Bryn?
So, just think of the word meaningful, full of meaning. It's going to vary from each and every person, from context to context, depending on what point you are at in your life. At one point, things that were meaningful to me was like staying up all night, and now I love to be in bed by like 8 o'clock. So the things that I make meaning from are very different now than what they once were. So what that means is exactly what these two gentlemen are saying is we have to ask. We have to ask people what is important to them, and we have to listen to it, and then we have to consistently provide other opportunities to update that information and to find ways to respond to what is meaningful for that specific person at that specific point in their lives.
Yeah, I don't really have much to add. You know, I was going to double tap on the listening piece. I think that's really important. And, you know, the other thing that strikes me is that, you know, again, as we continue to evolve new technologies and implement and try to figure out what does it mean for, you know, how relevant is it to the clinical decision-making process or my individual ability to make decisions about my health, you know, I think that we need to be building into our processes that listening piece, right? And so continuing to do a little bit of research along the way so that we can flex and, you know, so the good example of, you know, providing calorie counts at restaurants, has that really changed people's behavior? You know, like, I think that we need to think about, like, are wearables really helping people change their behavior? And, you know, how meaningful are they in the clinical setting? And just really being active listening as we go along.
I mean, I think it really goes back to this concept of, you know, don't innovate for me without me.
Yeah.
And, you know, oftentimes I think we're innovating really for ourselves because we, you know, want to make sure we're making a difference, but we're not really thinking about how we deliver that value back to the user. So kind of going to the other end of the title, talking about just the engagement piece. And so Brad, I'm gonna go back to you because I know you and I have talked a lot about this. When it comes to really connecting and engaging with veterans, I think, you know, the one thing that you know, we've talked about as a thing the VA does well is, you know, we're really good at connecting and learning from the veterans that we know about, the ones that come through our doors, are seen in our clinics, but the veteran population is much bigger than the ones that we see in the VA. And so, you know, I know you do a lot of work with the RVH program, thinking about, well, how do we connect with the rest of the veteran population? At least let them know that we're here. We want to learn from them, hear from them. What are your sort of thoughts on how, you know, as a system, we could sort of, you know, eliminate that blind spot, really?
Yeah, it's really tricky because the way that we do that is person by person. And there are technologies that can enable us to reach out to a larger population for sure, but it comes back to that meaningful engagement and that meaningful connection. And for veterans that we don't serve, for veterans who are not enrolled in VA, we don't really have great systems to connect with them, right? We don't necessarily know their phone numbers or the emails. We do have other ways. We can get creative. We'll hear from Evidation a bit about how we did that. With the Reimagining Veteran Healthcare design project that my team and I have been working on, we had a specific focus on the underserved, the unengaged, the disengaged, the unenrolled, veterans of color, veterans from a lower socioeconomic background, lower literacy, right? People who are very vulnerable and who are not connected with us because of perhaps maybe misunderstanding their eligibility criteria. It is complex. I don't get it. And I've been looking at it for a long time. But really going back and thinking about, so right now, the VA, we have about half of the veteran population is enrolled in VA, less than half than the veteran population is enrolled in VA, and a smaller subset of those vets are the ones who are using it. So if we have 19 million veterans in the United States right now, you know, that's not a whole lot, but we know that the veteran population is declining. And for VA and for our vets as well, as that population declines, it becomes more and more urgent that we're able to connect with and provide services to as many veterans as we can. But not just for the sake of providing those services. We know that their outcomes are better when they're engaged with VA, but we need to be the ones to change, to meet their needs. We hear this all the time, right? Meet them where they are, right? Where they are changes, and it grows, and we need to as well. And that is what meaningful engagement can get us to do, is to really connect with those people who need us most.
And so along those same lines, Ernesto, I know that you know, you've been involved in some of the pilot work that we've done between VHA and Evidation. And I know you guys as an organization really think about, you know, how do you find and connect with people? And one of the things that we were most excited about in terms of working with you all was leveraging some of that creative work that you guys do to really help us connect with veterans outside our usual channels. So how do you guys typically approach that, and what's your sort of, is there a playbook, or what's your kind of take on this?
So, the benefit of being a commercial entity, we are out there trying to do things in the consumer health world, is we can use consumer channels. We can advertise, we can try and get members to enroll and activate them around their health. With you and with other folks at the VA, we were able to launch really quickly a survey trying to understand what do veterans care about in their health and how are they thinking about kind of their health technology use, and whether or not they'd want to connect that health technology use into the VA. And I think we found the same thing. 54% of the people, it was like around 6,000 over a couple weeks that we enrolled in the survey, only 54% were actually self-identified as enrolling in the VA. But we were able to find folks, a large majority, I think it was around 700 or so, who said, you know what, I'm not, but I'm interested. And we can actually go out and act and give those individuals the right tools to make the choice of whether or not they want to enroll in the VA ecosystem. In terms of finding people, it's always tough, right? We, like anyone else, we are always trying to increase our diversity, try and find people that we think would have the biggest impact. And so we use a variety of channels. A lot of times we're trying to help people enroll people like themselves by making the case that when we kind of lift the, rise the tide, lifts all boats kind of thing, we can actually make some pretty big impact in the healthcare ecosystem.
Yeah, that's so powerful. I think, we were so, I think it was made so clear to me that, this obviously is an issue that VA can't achieve on its own. I think we have to be creative. We have to think outside of the kind of traditional box that we work out of. So this kind of public-private collaboration was so key. And Michelle, I want to go to you because I know that in some of your former work and current work, you've done a lot of work through public-private partnerships. I know you're involved with NIH and the All of Us program. And so, can you speak about the impact of finding ways of getting stakeholders from the government, from industry, academia, foundations, what's your sort of strategy or thoughts around how do you get all these, really sort of oil and water type of, groups to really work together in a way that's cohesive and kind of gives a unified approach to a problem like engagement?
Yeah, you have to unify around a mission. And you have to find the people that care about that mission in those different types of organization that can bring together the different types of expertise and resources that are needed. Because quite frankly, we can't all be good at everything, right? And we can't all have the resources to do everything. And I love this example of VA partnering with Evidation. And I wonder if you partner with other organizations like Vet Sports and things like that. I think there's a huge opportunity there. But from my experience, I think another thing that can be helpful for that co-mission evolution is programs like the White House Presidential Innovation Fellows and these opportunities for people to participate in civic tech service and come into the government and serve your country for a couple years and then take those learnings back with you to the private sector and embrace that mission wherever you are. And I think veterans are the biggest example of that, right? That is the ultimate service and sacrifice. And so whatever we can do, to really help push that mission forward, I think is the best way. I have a slide that I show sometimes from when I was working with the All of Us research program that has all of the different partners on it, and you can't read any of the names because there's so many. Wow. Because it not only takes the government and NIH leading the charge, it takes community health partners like the FQHCs. It takes large health research institutions and clinical care support. It takes different types of technology platforms to deal with the different types of data that are coming in, and then it takes all of the researcher services too. So it's a lot.
I'm going to just add one quick thing on that. I think you said it exactly right. Going out to all these different other communities is really important. But as we go out to try and bring people into our ecosystems, because that's really what we're trying to do, right? We're trying to bring them back to us, bring them back into the VA ecosystem. It's making sure that when you go out to those communities, you're using the language of that community when you do so. When we were collaborating with you in the VA ecosystem, one of the first things we did, we have copy editors, we have people that like all they do is write content. They're really great at it. But the first thing I did is I called up Calvin because he's a veteran. He works on our team. And I said, what is this going to sound like? What should it sound like? What should it look like? What is going to be meaningful to you and the veterans that you know and you interact with on a day-to-day basis outside of your work life? And that was like night and day, I think, in terms of what we were able to do is just by having someone that we could rely on that's part of that community.
No, I think that was so powerful, really going back to that message of the signaling that we can give that we're innovating, for you but with you, because we're really focused on what your needs are and in language and content that really speaks to you. I think that was so powerful. So I'm going to switch gears a little bit. I think you kind of segued us into this a little bit, Ernesto, in terms of having people sort of engagement, connecting with patients. I think obviously is one half of the equation. We want these patients to kind of pull back into something. And so I think, Sandeep, I want to go to you. I know you all at Bioformers think a lot more about the clinical side of this and, how do we engage patients back into clinical workflows and how we do that in a way that's additive and not subtractive, both for the patients but also for the care team. So, can you speak a little bit about what, how you guys approach engaging patients but really then getting them back into a care pathway in a way that's, really going to deliver value back to them but also making it, feasible for the care teams?
Yeah, no, thanks for that. It's having lived through COVID for the last couple of years, everybody got a fast track learning on how technology could play a really beneficial role, but also expose a lot of digital divides that disconnect patients from their provider teams, right? So it comes down to really understanding what are the limitations in access to care. So a good example of that was when the need for hospital bed and bed capacity became an issue because COVID patients were occupying those beds. It doesn't matter if you're a veteran or in the community, people didn't have access to care. And so those kind of restrictions started to open up opportunities for engaging patients on a new care site, which became their home, right? So that's really where we started to do some work with great partners like Brigham, where we were trying to understand how much of hospital level care could safely be delivered into the home where the patients could get the benefit of the care they would normally get in the hospital, which they didn't have access to. So that kind of led to building care pathways that allowed us to engage patients and giving them that option. Now, when you're presented to the emergency room, right, you can sit here and wait for a couple of hours, but you are meeting a certain profile, you have some other opportunities now that you can get the same level of care, but starting with that from the patient's perspective, right? Like, here are what you can expect. This is how you'll benefit, and then having them decide with you, this is the right approach for me, right? So that's how we started this, and everything that we worked on now builds off of that, right? So that's where you then go up to the next level, which is what kind of tools and technology can you use to make that safely happen and deliver that care safely. So then, we rely on continuous data that's gathered by biometric devices that give us a clinical picture of what's happening with the patients without them having to constantly have to participate, right? Because it's a lot of what I call Gen 1 monitoring and patient-reported monitoring solutions required constant engagement with the patients, where to the point, a lot of them said, look, I don't need this. So now, having passive collection of data that's clinically validated, that allows our team to get a clinical picture of what's happening to the patients and which ones are improving, which ones are deteriorating, and then build that into the clinical workflow, right? So as a clinician, the first question we get is, okay, if you're collecting all this continuous data, I'm not going to have time to look at it in the EMR, right? So then we have to step back and say, look, It's not for you to view. That's where our algorithms and automation come in to free up the capacity that everybody knows is limited resources, right? So everybody can benefit from having more time with their nursing team, more time with their doctors. So that's where I think technology plays a key role in taking that information, understanding clinically what's happening, and then representing it back to the care team so that you can make clinical decisions that then loop back into that care patient. So that's what we're working on.
Makes sense. So Bryn, I want to go back to you, and I'm going to try and pivot. This is sort of the, how do you cure cancer type question, but,
Mouse at a time.
Yeah. So, I think a lot of, or one of the kind of core questions that comes up with any new digital solution or tool is, especially in the VA where we have a larger than the non-VA population of rural veterans. I don't know, you live in rural Vermont, so you can sort of relate to this. Bryn was actually telling me, I think the other day, about how excited she was to get Starlink, and her download speeds went from the 10 megabits per second to like the 70s and 80s.
Yeah, and then he was like, I'm in the thousands. I'm like, oh, I guess I shouldn't brag about this then, huh?
But that's a real challenge. I know VA spends a lot of time thinking about this. I know from a human-centered design perspective and a health equity perspective, I know we've talked a lot about this. But sort of what's your take on that? How do we really, from a design perspective, how do we really, in an equitable way, focus on the digital divide coming across that?
Yeah, it's a huge problem, which is why we're talking about it a whole lot. However, when we talk about it, some of the things that I think that we fail to really understand is what that looks like from the individual human perspective, right? Being left out of services, being unaware of what's available for you. I live in the middle of nowhere, Vermont, dirt road off a dirt road, and I love it. And I am lucky that I can advocate for myself. I am lucky that I am a privileged, white, college-educated woman in the United States who has an amazing job with amazing resources that are afforded to me that I can self-navigate. I have a lot of neighbors who are in very different circumstances. And when we start thinking about leveraging, coming up with our digital health strategy, and et cetera, like strategies are important, but we cannot put just digital or the technology at the center of it. That will be an enabling factor in some ways, right? But it will also be disabling for others. So we need to really understand that what we are doing, inherently, healthcare is about humans taking care of humans. And we can automate some things. We certainly need to make a lot of things easier, information better and more readily digestible for our care teams, for our patients as well and their families. But at the end of the day, we also really need to be thinking through where we make those real investments in that true human-to-human contact and engagement, where we get out to people's homes, in their communities, leverage technology to help us build agile care teams that are like roving clinicians. I don't know, right? People live in communities. They enjoy their health or suffer in their misery in their homes, in their communities. And we as a healthcare system need to start to realize that when patients come to us, we think of them as, right, engaging in our system and they're the visitor. But we're the visitor in their lives, right? We are the ones who are the guests. And we have to start behaving like that, and we have to start understanding what it means to be a good guest, one that people want to keep inviting back for more. And I think that just little tiny fundamental shift in the way we think about patients and how we engage in their lives rather than they engage in our system can open a lot of doors for us to do that human-to-human piece a lot better and leverage technology to make that happen when and where people need it to happen.
I kind of want to get the same take from everybody else too. I know because you guys kind of represent the, I don't want to say big tech, but I think there's so much technology involved. But one thing we saw that Allison and Abraham was talking about is the role of people. And a lot of the work that I've done in virtual cardiac rehab, we use all types of fancy wearables and devices. But if you talk to the patients who've done well and you ask them what was the best part, and they'll just say, all of them will say uniformly, my coach. And so how do you all, and Sandeep, I'll start with you, because you mentioned algorithms and sort of using that to minimize the workload, but with all this data, with all this technology, how do you guys sort of maintain the focus on the people that are involved, including not just the patients, but giving them a human connection to really feel like they're talking to a person and not IBM Watson?
Yeah, totally. So, I mean, that's exactly right. So when this
Sorry
data...
if there's any IBM folks at the room.
So, no, that's exactly right. So even though the information coming in, it's still, so for example, when this happens where we are the remote team, we have layers of that, right? We've got care navigators are the ones that really know the patients, so well enough that they can have a conversation with them. But as they need to escalate their anything clinical, it goes internally to our team, who then can coordinate their care into the home, either with our partner services that we have or with the hospital that's responsible for their nursing team to go into the house itself, right? And then to extend beyond that, recently there's been programs that validated using community paramedicine groups, right? So you have the ways of actually having that high-touch workflow enable because of that single point of contact that the patient has. So they actually tell us, look, I can sleep well now because I know someone's watching over me, right? That's the feedback that we're getting. And because they get that sense of proactive approach to care when they're in the home, because you have to be hypervigilant that something is, it's not like in an enclosed hospital where you can run down the hall, right? So the fact that they're getting the perception and the feedback that we're hearing back is that they feel like they're being watched over. They feel like they're being looked after. And it's because it's a combination of the technology, but at the end of the day, it's that voice on the other end that's reaching out to them, communicating with them, so they feel connected.
Michelle?
Yeah, that's, I love that, that they can sleep better at night because they feel cared for. I mean, so that is a great goal. I wanted to take it back to, when you think about the research side of things, the example that always comes to my mind is that the All of Us research program was envisioned by Francis Collins as a fully digital clinical trial, fully digital. But then when it came to putting that into practice, they were not able to achieve their diversity milestones because you have to meet people where they are. And so I think that's one of the most critically important things is that the engagement models can't be just digital. You have to include other means of engaging. When we did the survey of FQHC participants, we asked them, would you rather get text messages? Would you rather get emails? Would you rather get phone calls? And a lot of them wanted phone calls. And so I think that it's really important to appreciate this digital divide, understand where it is and who it may be affecting, and then provide alternate methods and actively leverage those methods to bridge those gaps. And it's just really interesting, but we have to solve this digital divide problem, and sometimes it just comes down to broadband.
So I want to be mindful of time and at least give time for some Q&A. So we have about 10 minutes or so. So I want to open it up to the audience for any questions for our panel. In the front row.
Ernest Vertilli, Red Duke Strategies. So we talked earlier in the panel of... Thank you. Ernest Vertilli, Red Duke Strategies. So you talked earlier in the panel about the difficulty with getting engagement with veterans that aren't engaging with the VA, right? That they're not in the medical centers, like they're not coming in to do anything. There's no way to communicate with them. And it's difficult, right, because, the military community and the veteran community, it's a microcosm of the United States community, right, and people are everywhere when they get out of service. Some go to urban centers, some go very rural, and they're completely off the grid. Some have, service disabilities, service-related disabilities that are physical. Some have psychological disabilities. Some don't have any health issues and have no reason to engage with the VA. So it's really difficult. I can feel at times that there's so much, disparity between what it is that they're looking for and what they need, that it would take an entire team, an entire ecosystem. And so I wonder then, given that there sort of is an ecosystem of veteran service organizations and veteran empowerment organizations, what sort of this panel's thoughts are on what role VSOs do play and should play in an ideal world could play for the VA in terms of engaging veterans?
Yeah,
Great
it's
question.
such a great question. And with the RVH project, when we were specifically looking to recruit for vets who are not engaged with VA, we went to VSOs and had conversations with them and said, this is what we're trying to do, this is what we want to understand. We extra have to understand why, right? And where and et cetera. So our VSOs actively helped us recruit, and we were able to connect with a much higher rate of disengaged, disenfranchised, distrusting veterans than we otherwise would have. And that is crucial work. VA trust scores measure the trust of veterans who are engaged in the system, right? We're missing a huge portion of folks who are not enrolled in VA, and it could be because they don't trust us. And for many communities, for good reason, the federal government has done some pretty awful things to a lot of communities over the years, and there's a lot of trauma, and we need to do a lot of work there. And partnerships with our veteran service organizations, with county, with state, other communities are really, really important in how we first understand and engage, and then are able to move forward. And really closing and tightening that gap during military transition is really important work as well. And that space feels a little cluttered right now. There's a lot of different things happening, but from the service member perspective, from the ethnography that we've done, from going out and talking with transitioning service members, folks who are still in the military, and those who have left, there's just not an overarching understanding around what that could be like and where folks can plug in when they start to realize whoa, this is very different than I thought it was going to be. I thought I was going to be fine, and I'm not fine. So thank you for that question.
Great question. Others? I think they're gonna give you a better mic, so we can more meaningfully engage.
Oh, this one works. Okay, I can hold this way. My name is Justin. I'm a physician. I'm in the Office of Health Equity. I have a question just piggybacking off the last comment on trust. Are there strategies that you have found that have worked with different groups of people around trusting technology? We've talked about trust with the system, but there's so much work to do with trust around technology, and from your different sectors, I'm wondering if you can comment on that.
It's a good question.
Yeah, I'm happy to maybe kick off. So we've got around 4.5, almost 5 million people on our platform. They can connect lots of different wearable devices, Apple Watch, Fitbit, you name it. But we ask people tons of questions. We ask them surveys about their health. We ask them to participate in clinical trials that we do on our system. We ask them about how their day's been, all sorts of different things. And one of the primary drivers, one of the things that actually excites me about the work I do is our emphasis on trust and transparency. And so whenever we are collecting data for an individual on behalf of someone or even for our own purposes, we ask them. All of this stuff it's all under our terms of service, and it's part of our privacy notice. We don't have to do this, but it is imperative, I think, to our work to make sure that we are transparent with people about what it is we're doing and why, where their data goes, and to whom it goes. That, I think, is one of the biggest things you can do for an individual is just let them know.
And I remember, I think when we were working with you all, and I was very impressed by this, but just the sheer focus on being opt-in. Nothing was opt-out. Everything was opt-in. I think that's such a strong element, because if once you lose that element of trust, because you sign someone up for a thing that they didn't know about, no matter how small or large, you sort of lost it.
Yep.
I'm curious, Sandeep, to hear from you on this, because I know you guys are. It's one thing to sort of use technology to track things like steps and activity, but when you're dealing with patients with heart failure, something a bit more higher risk, how do you kind of get that element of trust?
There are times when patients just say, look, I don't want to wear something because I don't want people watching what I do, right? So we have to help them understand that this is the level of data, the difference between consumer versus clinical grade, right? Just walking them through what information is being collected and who it's being seen by, right? It's not going some random place in the cloud, like people are going to access it. It's going directly to your care team. And when it comes from, and this is also where we have a way of looping in caregivers and family members into the conversation. So there's actually a separate application that if they want to have their family members to help them coordinate, right? So it's usually a concerted effort between their care team, the family members, and then helping them understand what this is going to be used for and the benefit to them if they choose to participate, right? But at the end of the day, if they say no, then that's a patient that we can't enroll.
I mean, it all comes back to just asking people, right? And listening to what they have to say and respecting that. Most of the work that I do is research ethnography and doing more of the qualitative stuff. So each person is a data set unto themselves rather than one individual data point. And one of the research projects that we were doing involved rural veterans, and there was a mother and a daughter who I had cold called in some of my outreach. I called the mom to recruit her for this project, and she was very dubious and was one of the disengaged vets, and she was not so interested in talking with us. But I spent some time, building that trust, explaining it to her, what it was. We were trying to understand what our approach would be. We would come out to you. We would meet you at your home if you're comfortable with that. We want to spend some time. And she was like, my daughter's a vet too. Let me talk to her. If she's interested, then maybe. So she called her daughter, and they had a chit chat, and who knows but they called back and they said, we'll do it if we can do it together, and we don't want you to come to our house. And we said, oh, yeah, okay. So we found a library. We reserved a room in a library in their community. They came. We had amazing conversations with them, and were able to bridge that gap in a way that was a little bit different for another vet that we then had a conversation with at their home later on that day.
When we built our CHF program 10 years ago, at the end of the program, the patient was successfully not readmitted to the hospital, so our team went to collect their tablets. And the feedback was, wow, this is the best weight loss program I've ever been on. And so, because they were tracking their weight every day, right? They forgot about the clinical nature of what CHF does to you. But at the end of the day, they're like, yeah, they were just so into then getting used to the technology that they forgot that, they were glad to avoid the hospital admission.
Yeah.
So I think we're out of time, but Michelle, I want to give you a chance to kind of chime in on this too, and then you can kind of close us off in terms of, trust from the perspective of, a larger, health tech company now. How do you guys really think about that and really focus that as a core part of the offering?
Yeah, same. I mean, I think it's about respecting people and acknowledging that you own your own data. In the end, it's up to you, how you want to share those data. And then the burden is on all of us to prove to you that sharing in a safe and secure way is actually going to be beneficial, not only to you, but to everybody.
All right. Well, thank you all so much. This was a really exciting conversation. I hope that everyone's still lively and engaged. We have one more panel left, so we're going to thank our panel. Thank you all. And I think if people have questions, they can probably find us outside or after the talk. So thank you all.